Hey guys, I'm going to be teaching you EKGs for 12 leads. So initially the first step is, this is in the Lewis book, and this is the STEMI criteria. You have to have at least 1 or more millimeter in elevation, right, which is 1 box above the isometric line. This does not apply to V2 and V3. You have to have at least two contiguous neighboring leads. So what that means is, down here at the bottom, you're looking at the same part of the heart. So V1, V2 look at septal. If V1 was elevated but V2 isn't, this doesn't fit the criteria. Now, for V2 and V3, it has to be more than 2 or more millimeters in elevation. So 2 boxes raised. So let's get started on our EKGs. So right here, I have a 12 lead. So, like I said before, we read it left to right. Okay? So let's read this thing left to right. Is there P waves? Yep. Yep. That one's hard to see. Yep. So as you can see here, we have firing from our SA node. It's got to be above the atrias. This is our sinoatrial to have a P wave. Now, the QRS. How do those look? Really thin. Perfect. So, if they're thin, we're going to say thin. And now we're going to look at the R to R and see, is this regular or is this irregular? Okay, so what you would do is, I would get a piece of paper and I would put on the paper, draw out these two right here. I would then get the piece of paper and then check this one to this one, these two. Then I would check this one to this one, this one to this one. And we're going to do that to see, is it regular? These are regular. So this is normal. Okay, and then do I see any ST elevation or depression? Nope. Everything looks pretty good here. Okay, so we're going to say this is normal. Okay, so now that we've looked at that, let me erase this up. Alright, now that we've looked at that, let's figure out what we're looking at here on our 12 lead. So I like to group these together. So V1 and V2 right there. This is our septal. Now, for V3 and 4, this is our anterior. And now for five and 6, this is our lateral. Now this is going to be our anterior of the lateral, because then 1 and AVL here. So 1 and AVL. These are our lateral. but this is high lateral. High lateral. Okay. Now, with down here, we're going to look at now we're going to go 2, 3, and AVF. And this is our inferior. Now, the mnemonic is Sally. Ooh. Okay, so Sally. If we're looking at it, because we have S is septal, anterior, lateral, and inferior. So now when we look at this EKG up here, we have V1, V2, S, septal, 3, 4, anterior, 5, 6, lateral, I, 2, 3, and AVF is our inferior leads. And then you have your high lateral 1 and AVL. But just using the Sally mnemonic, looking at this, you'll be able to understand, oh, if I have elevation in V1 and V2, I'm looking at a septal myocardial infarction. If I have elevation in the lateral in 5 and 6, I'm looking at a lateral MI. Okay? So now, one thing to remember is that when you're looking at a 12-lead EKG, you're predominantly focusing on the left side. And what I mean is that you're looking at the left side, but you're also looking at the inferior of the left side posterior, but primarily left side. And here's why. Because depending on where the arteries are, here is what we're showing. However, the caveat to that is that with here, an inferior, this could be indicative of a right-sided. This could be a maybe right here of the right side. So now if you have elevation, if you ever see elevation in 2, 3 and AVF, inferior, you want to be careful with your treatment plan, because your treatment plan changes because you could be involving your right side of your heart and no longer your left. So that's a rule of thumb right there. 2, 3 AVF, you have to be careful with your treatment because it could be right-sided. And what that means is that if I have my heart the left side is a chunky monkey, right? Big old boy. Nice fatty. While the right side is thin. right? We don't have much pressure here. Okay? So now this is pressure dependent on the right side. Now, I don't want to get too far in the weeds with that, but just know that you want to possibly think about a right-sided MI with 2,3 AVF. You might want to think about doing a right-sided EKG. Okay, so that's pretty much what we're looking at right here. Now, let's look at some possible problems. Okay, so now looking at this EKG, already we can see some elevation. If we look at our rows here, so V1, V2, this is your septal, anterior, lateral, and inferior. Okay, so now if I look at my septal, that looks pretty clean to me. That's pretty straight right there. That's pretty straight. Let's look at V3 now. V3. Yeah. Our T wave's looking a little funky here. You know, we'll take a peek at that. Okay, but otherwise, we're just looking at that piece right there. We'll keep our eye on it. And now we'll go to our lateral leads. I'm not seeing one box, right? There's a box. There's a box. I'm not seeing elevation greater than one box. Okay. So it looks like that lateral lead looks fine. Now let's go play on the other side. If we look at one, I got some depression. Depression. What lead goes with one? AVL. Okay, now that's some depression. That's some serious depression right there. Okay, so now we see that. Let's look at our inferior leads. That's concerning. That's concerning. That's very concerning. Very concerning. Very concerning. Now let's look at AVF. Very concerning. Very concerning. I'm seeing ST elevation here. Right? So if I were to isolate this, okay, so remember what I said. This right here is our inferior lead. Okay. So now let's look at our reasoning here. Okay, we find our isometric line. We just did. Right there. Okay. Well, that's greater than one box. That puppy's sitting all the way up here. That's greater than one box. You see how it's elevated above that box right there. You see the elevation there? You see how it's above one box, which was that our criteria? 1 millimeter in elevation, besides V2 and V3, and we have to have it in 2 neighboring leads. Well, I think we're at 1 millimeter. Yep. Yep. And now we have to look for 2 or more contiguous leads. Well, I got elevation here, here, and here as well. Okay, so I'm thinking there's probably a good chance that I'm having a heart attack. Well, now, if you look back at 1 and AVL, 1 and AVL are fed by the 1 and AVL are fed by the left. I'll just write it out. They're fed by the left coronary artery. Okay? So now, if we look at 2,3 AVF, so 2, 3, that's fed by the right coronary artery and the left. Oh, shoot, I put coronary. Okay, so now in reciprocal changes, reciprocal you will see changes to the ST segments in opposite leads and basically what this means is that you're looking at the same injury at a different view. Okay, so now when we look at this, when you look at the high lateral, which we're starting to see ST depression, right? And we have that circumflex, which the circumflex is written out like this. So you'll have LCX. That's how you put your left circumflex. So So now for my inferior, well, the left circumflex artery, it comes off the aorta, is more on the lateral side of the heart, so like the left ventricle side. And I'm sorry, yeah, left ventricle, left atria, left ventricle side, and it wraps around the back. Well, the inferior also wraps around the back. So they're going in the same, they're meeting in the back areas. Okay, so now that's what I was meaning, is that you're seeing it from a different view. Okay, so we'll clean this up. So, just remember, we follow this in a pattern. Is there P waves? Yes. P waves. How's my QRSs look? These are good. Good. Not good. Not good. Look at how wide that is. Okay. Oh shoot, not this. Sorry. I forgot it was a positive. Up. Okay. So now that we've looked at that, let's go check another one. Alright. So take a look at that one. When we look at this, okay, we're already seeing elevation coming around. Let's go to and march out our areas. Okay, so we have V1, V2. Here is our septal. Now we have V3, V4, do you remember? Anterior. Lateral. Now we have Q3 AVF. Okay, this was our inferior. And then we have our bilateral. So I'll just put HL. Okay, so remember the Sally mnemonic. Septal, anterior, lateral, inferior. Alright, so if we move all this junk, let's go looking at what we got here. Alright, so we're checking our septal. Nothing. Anterior. Looks pretty good. Got some peak D waves. 5 and 6. ST segment looks fine. 1. ST segment does not look fine. So where's my neighbor lead? AVL. That doesn't look good. Okay. Now here's our reciprocal lead. Remember, the one that looks at a different direction? Here's 2, 3, and AVF. Yeah, I'd say that's some depression. I would definitely say that's depression. I would say that that's depression. So now we can look into this more. It's hard to see, but it is greater than 1. Most definitely greater than 1, right? We found our isometric line. And we're tracking up around here. So now we're looking at a high lateral of the heart here, right? That is a lateral MI. So a lateral STEMI. That's what that is, right there. Okay, so now let's move on to the next one. Now, look at this one. This is an ugly one. Alright, so initially, we look at septal. What do we see? It's looking like we have some elevation. Right? Yep, that looks like elevation. That looks like elevation. So here's my septal. Look at that. Look at how bad that elevation is. Look at how much worse this just got. And we got 5 involved too. So what are we thinking so far? Well, so far, we're thinking we're having an MI. I mean, Stevie Wonder could see that that's more than a couple boxes. Well, how about over here? Yeah, that looks pretty bad too. Okay, so we got V1, V2, and V3, V4. And now, this one is strange, because when you're looking at the EKG, you're looking at areas that may be fed off the same artery or near that same area, right? So if we're looking at the septal right here, we're thinking this is our left anterior descending. Okay, there's our LADs right there. Well, now, what's 3 and 4? Well, 3, remember, that's our interior. Guess what that's also fed by? That's also fed by the LAD. What's 4 connected to? 3. And it's the anterior. So what is it fed by? The left anterior descending. Well, 5 is that little oddball that I was talking about. Because 5 is a lateral. But if you think about how it looks on the front, if you're looking at a heart, we're actually feeding the anterior lateral of the front, right? Because all these, V1 to V5, are pretty much anterior leads. I don't remember if 6 is or not. But we're looking at a full anterior snapshot right here because it's the LAD. And the problem is that with the LAD, if you look into the left coronary artery, or the left anterior descending, the LAD feeds a lot of the heart. And so when you see somebody having a left anterior descending MI, they call the LED, this is the widowmaker. Right there. Because the LED feeds so much of the heart that if you start letting tissue become ischemic there, it's probably time to say some goodbyes. It does have some right ventricle feeding to it, but it mainly supplies the anterior part of the left ventricle, septum, and apex of the heart. That's a lot. So if I'm looking at this and I see that elevation, okay, you can have a STEMI in multiple areas. Because if we were to look at this and go, well, I have elevation in multiple leads, not just in two. I have it in V1, V2, which is my septal region, V3, and V4, which is my anterior. And I got a bonus right here for a lateral. So this patient right here is having a septal anterior MI. Right there. And that's how you read those. Just like that.